their chairs, their audience. In the following minutes, I would like to present you the progress of my PhD topic. The title of my PhD is The Role of Mental Health Status in Pediatric Inflammatory Bowel Disease. I would like to start with a brief summary of my first project. Pediatric patients with inflammatory bowel disease have decreased quality of life compared to healthy individuals. And this impaired quality of life is associated in these patients with depression, anxiety, poor physical activity, and poor school performance. Our analysis indicates that proper psychological intervention can improve quality of life with 5%. Pediatric gastroenterologists should collaborate, therefore, with psychologists in the multidisciplinary care of these patients, and further research is needed to specify the patients who need more advanced psychological interventions, and the policymakers should mandate psychologists in every pediatric IBD centers. I'm a pediatric gastroenterologist. I'm working in the Bethesda Children's Hospital, and I'm a PhD student here at Semmelweis University. With my team, our vision is that pediatric IBD patients, despite their illness, will have excellent quality of life. And my mission is to identify every kind of psychological intervention which can improve that. Last year, I've started 2 projects which is related to psychological interventions and psychological aspects of the disease. My first project is to investigate the effect of psychological intervention on disease activity and quality of life of IBD patients, and it is done by systematic review and meta-analysis. It is an important topic because we know that the number of IBD patients is emerging worldwide, and 25% of the patients are diagnosed in childhood and adolescence, which is a critical period for psychosocial development. I mean self-esteem formulation, school and academic development, and also social and family functioning. And we know from studies that children with IBD are increased risk for depression, and the younger the patient, the higher risk for the work disability. And current guidelines focuses on pharmacological and nutritional support, but there is lack of advice on psychological management. Psychological interventions can help different ways to these patients. First, to treat comorbid depression, anxiety. Second, to have to improve quality of life. And for third, there's a hypothetic way through the hypothalamo-pituitary-adrenal axis. They can have a modulation of the inflammation. So our aim is to understand the impact of the interventions on disease activity and quality of life. We have our clinical question that does psychological intervention change the disease activity and quality of life of pediatric IBD patients compared to standard care? And our patients are children and young adults, and the intervention is standard care with psychological intervention, and we have outcomes which include also clinical and psychological ones. And our hypothesis is that psychological interventions increase the quality of life and decrease the disease activity in these patients. Here you can see our search key and our flowchart of the selection. In the beginning, we had more than 9,000 articles, and at the end, we have 11. I would like to talk to you about my results. All of our studies are randomized controlled trials. There are some studies which use different measures, different scores for the outcomes. So with the help of our statisticians, they transformed them to a common scale. And at the first slide, you can see the Child Global Assessment Scale, which is a health-related quality of life score in pediatric IBD patients after 3 months. And we have here more than 200 patients. As you can see, with the psychological interventions, the health-related quality of life improved with almost 5 points, which is statistically not significant, but clinically it's a relevant result. In the second figure, you can see the disease-specific quality of life score. It's an impact-3 score. The same, the higher scores means better quality of life. And in this figure, you can see that the disease-related quality of life improves with 2.8 point, which is statistically significant, but clinically we don't think it's a significant result. On the third plot, you can see the child depression inventory, which is a 0 to 54 score. The higher scores means worse depression symptoms, and as you can see, we made, despite this small number of studies, a subgroup because we saw that in one study, the first study with the intervention, they made a greater improvement, and that's because in this study they had patients with clinically significant depressive symptoms, and as you can see, it improved with 2.3 points, which is not a statistically significant results. And the fourth plot, you can see the anxiety score. As you can see, psychological interventions didn't modify in our analysis the anxiety score significantly. Of course, our study has strengths and limitations. The strengths, these are randomized controlled trials. The patient population are homogeneous. I mean that these are pediatric patients with inactive disease, and the limitations that the low sample size, and they used multiple scoring systems, and the heterogeneous interventions in the length, intensity, and the nature is also a limitation. For the conclusion, we can see that psychological intervention can improve the quality of life of the patients with inactive disease, and the cognitive behavior, decrease depression, severity in pediatric IBD. With clinical depression, for implication for practice, it is important to early identify patients with depression and choose and appropriate individualized psychological interventions. Also important, and for further research, more studies needed with larger patient populations. And there are some studies which used hypnotherapy, and we have seen that this kind of treatment have different effect, and it should be also studied further. Currently, we're in the manuscript status, and we plan to submit it in September. My second project is to investigate the effect of depression and anxiety on disease activity in newly diagnosed patients. And it is an important topic because we saw that IBD diagnosis in children and young adults increases their likelihood of facing mental health concerns. We see that mental health conditions are more prevalent in pediatric IBD patients than the healthy individuals. And we know from adult data that depression increases the risk of surgery and biological therapy and second-line therapies. So it can be a problem in the disease course, but we are lack of data on the pediatric population. So our aim is to investigate the effect of mental health status on the clinical course in newly diagnosed pediatric IBD patients. And we have a clinical question that does initial mental health status affect the clinical course of pediatric IBD? Our patients would be newly diagnosed pediatric patients, and we would measure depression and anxiety in a common scale, is a RCADS at the diagnosis and after the induction, and our comparator that no presence of the depression and anxiety, and the outcomes are the biological, surgical therapy, and the dose escalation. And our hypothesis is that mood and anxiety disorders affect the clinical course in newly diagnosed pediatric IBD patients. To summarize my projects, first project planned to submit in September, and I would like to finish my second project next year. I would like to finish with a quote from Maimonides: "The physician should not treat the disease, but the patient who is suffering from it." Thank you for your kind attention.
Congratulations on your presentation. My question would be regarding your first project that you mentioned, I think 2 different disease activity scores. And my question would be that what are the main differences and in which cases, scenarios are they used over one used over the other one? Thank you.
I will go back because these 2 scores are used for colitis and also for Crohn's disease. And PUCAI is based solely on the anamnetic questions because it's based solely on the symptoms of the patients, and PCDA is partly based on some laboratory data. And I can say both of them are used in studies, but PUCAI is much more reliable in the common practice because, for example, the guideline for the severe colitis is solely based on the PUCAI scores, and each day, if someone has flare-up, we have to measure first that, and we have to make the main decisions based on that. The PCD is not so reliable, but it's also the best score what we have in this Crohn's population.
Thank you.
When I saw your result, I was really surprised because you presented only 3 studies regarding the outcome in your first project. So what do you think, why? It seems a really obvious target for studies, right? So it's, there are many patients, the psychological intervention is relatively available, and also this idea was circulating in the community for many years that there is a connection between psychological factors and IBD. So what do you think, why there are so little number of studies available in the literature?
I think one answer, which is not the best, but it's an answer, that the pediatric population, despite its emerging the number of the patients with IBD, I can see in pediatrics, but there are less because we have many adult data, and we have much more from the adults. But the other thing is that even if we talk about children and adolescents, it's a heterogeneous population. I mean that in this childhood, adolescence is a special period, and it is much more important in this connection with the mood disorders. So I don't know the exact cause for that, because I have seen that there are some authors who treat or who is connected with this topic, but I know that there are many centers, mainly from Netherlands and the USA. They are the main places where they cope with this problem. But I think I know some information about the European Pediatric Gastroenterology Society, that there will be some further studies on this topic. So yes, this is a need for further research.
Thank you. And regarding the adult population, so do you expect a different result than in an adult population regarding these interventions?
We think, but it's just not a database thought, but pediatric population is much more open for these psychological interventions, and it can have and these problems. I mean that, for example, depression and anxiety doesn't have a long history in this patient, so it can have a more effective effect. And we see that in every intervention, or not every, but most of the intervention, also the parents were included, so the supportive community is also important, not just in the treating the disease, but also this aspect.